A good surgeon is not someone who does not have complications, is someone who can manage his complications well. So let's dive straight into the complications, and effectively they're going to be either pre-op, intra-op or post-op. When you're talking about pre-op, this has been spoken over and over again, but repetition is good. When you see a long leg x-ray in your outpatients and you see that there's a varus, the immediate instinct is, okay, this can be a patient who can be thought about for an HTO. But what is important is that you need to look at the angles, and what you realize here is that the culprit is not in the proximal tibia, the culprit is in the distal femur. Conventionally, the thought process is whenever it's a varus, think about a HTO, whenever it's a valgus, think about a DFO, but that's not true. So you need to plan, that's the first thing. So how do you prevent? And this is going to be over and over again reiterated in these two sessions, that you have to plan on a scanogram, you have to plan. Because if you don't plan, you're definitely planning to fail. And this really holds good. When you're looking at an x-ray like this has been spoken in the previous talks, when you have a significant deformity and your Michelitz line is not going in through the articular surface, think about the fact that you may require a double level osteotomy. So don't shy away from it, think about it, talk to the patient, and then plan accordingly. When it comes to your intraoperative complications, let's touch these points in a stepwise manner. You can have complications right from your exposure to the height of osteotomy, to vascular injuries, to having an intra-op hinge fracture, to correction or to having a slope change. So let's talk about exposure. Conventionally, it's been taught that you go ahead with a typical anteromedial approach and get a great exposure to see all the structures. Christian Clay has published about these mini incisions, and he's a great surgeon. But I would consider myself to be an average surgeon, not a master of osteotomy. I want to see what I want to cut. I want to see the structures that I handle. And in that sense, in my hands, MIS is not something that I'm looking at. I want a formal incision. Handle the MCL with care. You don't need to disrupt the deep MCL, but in a meticulous manner, you need to release the superficial MCL, because it's well proven that when you don't release the MCL, your pressure intra-articular is much high, and that can actually cause overloading. It can cause iatrogenic fractures. So you need to do that meticulously. And I think Clement's video was great, where you can reach right up to the posterior aspect, feel the proximal tib fib joint on the posterior aspect, and that tells you that yes, your release is adequate. You need to do that with caution in those with laxity. What about the height of osteotomy? Well, even in the previous talks, we've not spoken about this. Where exactly is the right osteotomy? Is it 4 centimeters? Is it 3 centimeters? So think about me, if I'm 5'11", and if someone is say 5'2", does 4 centimeter remain equal in both of us? That's not the case. So what you need to identify is on your exposure, you look for the pes. You look for the upper margin of the gracilis. If you're doing a concomitant ligamentous intervention, if you're going to harvest your gracilis, at least make a cautery mark so that you know that's the level of osteotomy. If you go proximally, the thought process is that, well, the osteotomy is going to heal because it's a horizontal osteotomy. But understand, there is inadequate space for screws, and then invariably, because your D screw goes into the osteotomy, you tend to skip it. Your screws are too close to the osteotomy, and if you're doing any kind of concomitant ligament or meniscus work, that becomes a challenge. What about too distal an osteotomy? It's an oblique osteotomy. It comes into the diaphyseal bone. Your healing is going to be delayed. Your screw trajectory is not great, and your anatomical changes are something which are beyond your control. Something which is very, very important is how do you take your posterior corticotomy? And that's where the incidence of vascular injury is something you need to be aware about. On a cadaveric study, it's been shown that the popliteal artery is not too far away from the posterior margin of the tibia. And in this study, they measured the vascular structures at 2 centimeters and 5 centimeters from the posterior articular surface. And at 90 degree, it was the furthest away, where at 2 centimeters, it was 7.7 millimeters, and at 5 centimeters, it was 11 mm. Also, you need to understand that when you do your osteotomy, keep in mind your coronal plane. So if your blade is going from 0 to 30 degree in the coronal plane, then that's a safe zone. That means if you're coming from anterior to posterior, the chances of disrupting the vessels is much higher as compared to going more horizontal, and that's going to prevent your mediolateral incision or corticotomy is going to be less harmful. What about the direction of the saw blade? If you look at this, when you're using an oscillating saw blade, it's not as if it's going only in one direction. There is a significant oscillation, and you need to be aware about how much of oscillation can be there. As much as 35 millimeters is what the oscillation, what you're looking at. So the direction when you're directing the saw 10-degree anterior to the fibular head, that is the safest. So if you want to prevent these intraoperative complications, remember, keep the knee at 90-degree flexion. Use a retractor between the posterior aspect of the bone and the popliteal vessels. Your saw angle at less than 30-degree in the coronal plane. Saw is directed 10-degree anterior to the fibula, and you can think about the falcon blade or the precision saw where the oscillation is limited just to the tip of the saw as compared to the entire blade oscillating. What if you have a lateral hinge fracture? So Takeyoshi had described this in 2012, where not much was spoken about the intra-articular fractures, and they described 3 types of fractures. So in type 1, you have a fracture which is running into the tib-fib joint. They have reasonably good stability. Type 2 is where the fracture is running distal to the tib-fib joint, and those are the potentially unstable ones. You feel that you're away from the articular surface, but no, biomechanically, those are the ones that you need to be worried about. And the type 3, which runs into the articular surface, and these are the ones which are possibly arthrogenic, and they are because of inadequate release or opening the osteotomy too much. So what happens when you have these osteotomies, or you have these hinge fractures? The first thing you need to be aware about is the incidence of these fractures is much more on CT than on X-rays. And you might be in denial thinking that no, it is intact. But you do a CT, you'll realize the incidence can be as high up as 13% to 44% in some studies. When you're opening the osteotomy more than 13 millimeters, the chances of these fractures is further high. So you need to be careful about that. How can you prevent this? When you're doing your posterior cortical osteotomy, see to it that you go nearly up to 70% of the total width. That reduces the pressure going proximally into the articular surface and reduces the chances of a fracture. Now, God forbids, if you have these fractures, do you need to panic? Not really, because in most of them, the stability is good, especially if you're not using spacer plates and you're using angular stability plates. So spacer plates, for those who are not aware, are like the Pudu plate. As compared to that, an angular stability is one like a Tomofix or a new clip, which are longer plates and allows to get angular stability. How do you prevent these fractures? The first thing that you can do is that you can use a hinge wire. Now you can go from distal to proximal, or you can come from proximal to distal. So as you get your saw across, the saw is going to skive against the wire, and it's not going to perforate the lateral cortex. If not, I know few of my colleagues also use the hinge screw. That's completely valid. And this is something helpful, that if you have an iatrogenic fracture, you can stabilize that by using a hinge screw. If, God forbids, you have a fracture, in type 1, you really don't need to do anything, especially if a locking plate is used, because that acts like a fracture and you're stabilizing it. In type 2, again, if the locking plate is there, you're still good. But if it's a spacer plate, then you need to go on the lateral side and stabilize that either with a staple or with a plate. And in type 3, you can use a screw across the fracture so that the articular surface is restored, and then you can open the osteotomy. So just a depiction of the same. Type 1, you can use a screw. If need be, type 2, you can go on the lateral side, fix it, and type 3, you can use a cancellous screw all across. What about slope alteration? Sorry, I'm just going to exceed by a minute. Now you need to be careful when you're opening up the slope. So the noise technique of tree triangle, that means your posterior opening is going to be more than anterior opening. We have heard this in the previous talks, and the gap ratio is approximately 0.67. That indicates that you have maintained the posterior tibial slope. Now, iatrogenically, if you want to correct the slopes, because if you're doing it with ligamentous insufficiencies, that's a different ball game. But conventionally, your osteotomy in a high tibial osteotomy should be a trapezoid-shaped osteotomy. How do you do that? You're going to keep your wires in the slope of in the direction of the posterior tibial slope. And what I mentioned earlier, you're going to do a posterior cortical osteotomy. What about under or over correction? And this is not something uncommon, because if you don't plan pre-op and if you just rely on the alignment rod, understand your planning is on a weight-bearing X-ray. When you're doing it non-weight bearing with a cautery wire or with an alignment rod, you're not getting a true picture of the same. So again, if you want to prevent these complications, plan on calibrated scanograms, see to it that you do not cause any joint line obliquity, protect the hinge, and care needs to be taken when you're taking the care of the MCL. Lastly, what about the post-op complications? All the conventional knee-related complications like infection, DVT, non-union, and implant-related complications are there. A quick word about non-union, more common in smokers. It's non-progression of the osteotomy. How do you see this on serial X-rays? You look at healing percentage, and you need to calculate this on every serial X-ray, and that should keep on reducing. That tells us that it is healing. You heard this in the past that more than 60 years, high BMI, and if you're opening more than 10 degrees, these are the ones who can have a delayed healing. Smoking and unstable hinge fractures again cause delayed healing. You need to be aware about that and counsel the patient accordingly. If it does happen, you will go ahead and do an autogenous bone grafting if your osteotomy is stable. Lastly, be careful that your screws are not prominent, because they can irritate the soft tissue, they can cause neurological injury and other complications related to the same. So there are 7 golden rules. That's my last slide. First is plan, plan, and plan. Second, adequate exposure and a good MCL release. Third, safe techniques to prevent a hinge fracture. Strategies for vessel protection, that means keep the knee in 90-degree flexion. Your saw direction and your retractor is what you're going to use. Always do a biplanar osteotomy. These are inherently stable osteotomies, and an angle stable locking plate is something which is helpful. And unfortunately, if it goes into delayed union or non-union, you can think about doing a bone grafting. Thank you.